Coffee for this round. All right, everybody.
You want to try it?
I'm sure you were all thinking in depth about acid base, protein, if you're peel-it foaming while we were on break. Does anybody have any questions? Anything you come up with is confusing while we were, no? All right. I didn't think so. Here we go. Colonel Gendron is going to start early, and I'm probably going to finish early, so hang in. All right. So hematuria, also bad, right? The filtration mechanism of the glomerulus is supposed to keep them in. So we need blood for various reasons. Right? Write that down. So we should not be peeing it out. And like the true culprit here, I mean, the gross hematuria is what the patient's going to come in. They're going to see that. It's going to be remarkable and scary, and they're going to come in and tell us. The real culprit I was talking about, like our incidental findings, is going to be that microscopic hematuria. So there's a few red cells being spilled. Not enough to turn the urine any different color, but enough to see it on a lab under the microscope. And so that's why our microscopic analysis is always so important. Like I was saying, just a very simple concept that we just reinforce in here. Urinalysis, dipstick, micro, and culture, right? So UA, dipstick, micro, and culture. So all should go together as your group of tests that you would order if you're investigating anything for possible renal disease, right? And we've already discussed this was already in the first lecture, is that urinalysis dipstick is going to pick up a lot of different things that might not be blood cells. So it might not be a true hematuria. We have profound hemolysis and we have a lot of hemoglobin or myoglobin in the urine. It's going to be positive. When we look at the dipstick, then it's going to be negative. Okay, so those are pigment nephropathies. That'll be a false positive as far as actual blood being in the urine. Okay, so more than 3 red cells in a high power field, that's technically hematuria. Lots of different reasons. This is one thing we're going to harp on from here all the way through the rest of it, and I guarantee you this will be on your pants. As an old smoker with painless gross hematuria has bladder cancer. All right, just remember that now and take it with you. Okay. So this slide might seem, I don't know, it might seem silly as a part of a historical perspective, like taking a patient history. But if that patient can elicit to you when the majority of the hematuria is occurring, you may be able to identify whether it is a renal or an extrarenal source, right? So if it's initial, then it's probably, we're thinking that it's toward closer to the urethra, so it might be urethritis or something like that that's causing your urethral stricture that's bleeding, something like that. At the end, now we're thinking it may be in the bladder, so still probably extrarenal, but total hematuria like throughout the entirety. So if the blood start is only when they start or only when they finish, that's useful historical information. If it's throughout, it's less so, but it's more likely to be a renal source. So that bleeding actually coming from the kidneys itself rather than one of the other structures in the genitourinary system. Okay? And again, is the patient going to know that? More often than not, no. But if you can elicit that bit of history, it's just useful additional evidence for you about what might be going on. So it helps you diagnose the problem. History is no different than any other history. All right? When did it start? What are you even doing? What are the meds that you want? Here, and profoundly as far as the renal system and the genitourinary system as a whole are concerned, smoking is very bad for them. Smoking is bad, you can write that down too. But smoking for the genitourinary system is the primary culprit in most of our renal cell carcinoma and bladder cell carcinoma. The other big one are these people who have an occupational exposure to like certain dyes or solvents will also have experienced much higher rates of cancer, and if you put the two together, that patient really has typically a bad outcome. All right. And here's, when we talk about these and we collect them together, different lower urinary tract systems, like you've heard the terms dysuria, you've heard of frequency, urgency, those kinds of things. Are any of those other symptoms present? And I know we haven't listed them yet, but again, in a good history of hematuria, a lot of times that goes along with infections, inflammatory states, or things like stones. So in most of those cases, dysuria will be present as well, right? Painful urination. Have a kidney stone, if you have a rock tearing through your ureter, it hurts. And so when you pee and move it along the system, that causes dysuria, okay? any other thing, right? Pain, urethral discharge, trauma, okay, so on and so forth. Renal or extrarenal causes, this is what we're going to be getting into for pretty much the remainder of this course, and this pretty much covers bleeding sources in the urology side of the house. So anything that's not involved, anything from the renal collecting system, the renal pelvis down, really the urologist problem, anything in the kidney is a nephrologist problem, and that's what we're going to be talking about. Okay? You guys like stupid acronyms? I don't. But there you go. Lots of differential diagnosis. And honestly, in ClinCore, you guys have, or throughout, the clinical courses that you've had, formulating an appropriately sufficient differential diagnosis is probably one of the hardest things to do as you approach patient care. Because you really have, your aperture has to be very wide, of course, but it has to be appropriate for the diagnosis. And so, some of the things like this, like what should you think about as this patient comes in and they're bleeding from their urethra, right? They're bleeding into their urine. It could be a ton of different things, and these are the most likely, all right? Fever, that's bad, because either they have a fever and a stone, or they have a fever and they have an infection. That's either pyelonephritis or an infected stone. Neither one of those things are good. Edema, so that could be a sign of renal failure. CV tenderness, probably same thing, stone or pyelo. Anyway, just physical exam. Most of the time, somebody comes in complaining even of gross hematuria. They're not going to have anything on physical exam. It's going to be completely clear. You're not going to find anything, right? So most of the time, I shouldn't say most of the time. A decent percentage of the time, all right. Urinalysis, again, same thing. Remember the rubber match example? You get one, it's positive. You get a second one, it's negative. You get a third one to see which one was correct. If you get two that match, so negative, negative, or positive, positive, you're good. Take it from there. But what you need is to find out which one was correct if they are two different results. All right. And RBC CAS, right? Does that go with? You guys remember RBC CAS? Glomerulonephritis. Right? It was only in the first lecture, and we're going to hammer it home here coming up on Monday. But RBC CAS means essentially significant bleeding in the kidney itself. Remember, the CAS is a reflection of what's happening in the kidney and the renal tubules. When you have sufficient bleeding to create CAS, you're losing a lot of blood there in the actual kidney. All right. And micro, this is all redundant information, so that's why I'm going a little bit fast, right? Protein, blood, urine, bad. Got it? Okay, good. Urinary cytology, this is one we might not have talked about too much yet, but if you do have persistent hematuria, one of the things you should start to think about is urinary cytology, because one of the things you think about is it could be an extrarenal source, being bladder cancer. Urinary cytology also will be useful in any urothelial carcinoma. So true cancer of the urethra is extreme zebra, like a unicorn. Ureteral cancer, less so, but still pretty rare. Cancer of the renal pelvis, anything there might slough off urothelial cells and also slough off some blood. So you might have that. What you're really looking for in the urinary cytology is abnormal morphology cells indicating cancer. Okay, because your hematuria is one of the early presenting signs of cancer of the GU tract somewhere. All right. Again, one of the reasons why you can't just let it run, right? One of the reasons why you can't just say, "Oh, this is no big deal, it's fine," even if it's microscopic hematuria, or run it up the tree, see what you find. All right. And this is all later down the line, but the big one here is, remember we talked about CT urography, right? It's a three-phase look at the kidney. It's going to explain what is going on and why, and the vast majority of cases of unexplained persistent hematuria. So that is your workup for unexplained persistent hematuria. You can get a CTU, and that is something that we can order. Doesn't mean you need to refer to the urologist to get this. It means get it and then refer them to the urologist, or get it en route to urology. So that, or nephrology, either one, whichever one you think they need to go to, so that when they get there, the first step of the subspecialist isn't ordering a test that you could have ordered, that they could have already had that information. You know what I mean? You wait, how long do you think you're going to wait for, nowadays it takes 4 weeks to get into primary care. Then you got to convince the primary care to give you a referral to nephrology. Then you got to get the referral to nephrology 6 to 8 weeks later, maybe. Then you get to nephrology and they're like, well, why didn't they order the CTU? I got to send you back and then I'll see you again in another 4 weeks. You know what I'm saying? So get all the information you can get before you send them on to your subspecialist. Don't need to know this, but AUA does stratify microhematuria based on the likelihood that the patient has cancer. And if you just look at it, you get older and you smoked more, you go from low risk to high risk. You know, the older you are, the more you smoke and the more blood in your urine, the more likely it is to be cancer. That's really, that's this in a nutshell. So there's no reason to memorize these. Just understand that there's risk stratification. And where does this come into usefulness for primary care, honestly? Huh? Screening referral, really more than likely. Like, I'm much more likely that I'm going to refer on this person earlier who is spilling more blood, who has a higher smoking history, and is older for that cystoscopy to see if they have cancer in their bladder. Maybe I'll hold on to the low risk patient and see if I can work it up a little bit for them. So really, it boils down to a CPG, like a referral guideline. You know what I mean? So there is utility of it, even though it seems obvious. And then again, if you think it's a glomerular source, we're sending that patient to nephrology. If you think it is an extra-renal source or something that might require surgical intervention, that is the urologist's domain. Okay? And this is the chart for you. Pseudohematuria, it's a real thing. Okay. So is false positives on Wyatt cards and people eat a lot of beets or red meat. They might have some pseudohematuria. Anybody ever take Ceridium or prescribed Ceridium before? Urinary tract analgesic turns your pee bright orange. It's hilarious if you put it in somebody's coffee. Not that I would ever say to do that, but they won't know it's in there, and then when they pee, it's bright orange, and it might be funny. I don't know that for a fact, but I'm just saying it might be. Anyway, if you don't tell your patients that their pee is going to turn bright orange, they freak out and think you made them worse. And that will also potentially, if they're on it, because the reason I bring this up is because Ceridium is over the counter. Patients usually try to self-treat before they come and seek care, so they might have taken a urinary tract analgesic. If you don't know that, you might get false positive hematuria for somebody who has a simple UTI, doesn't actually have any bleeding. So just understand that's really important to get medication history, even over the counter. Things that patients have tried is important to understand. Okay? And yeah, things can turn your, I'm not going to ask a question off this slide. It would be hilarious though. Would phenolphthalein turn your head red, brown, dark brown, light brown, orange? I ain't gonna ask that question. So look at that and tell me if it's too subtle. All right. So just understand that, and I guarantee it's on the pants. Guarantee it's on the pack rat too. Guarantee it's on my test. There you go. You guys already have one question for the urology section, so you're winning. We are winning on a Friday. So now we're going to go into acute kidney injury. Anybody have any questions about the stuff so far? Probably lots of questions. Any organized thoughts that can come out as a question at this time? No. All right. Fair enough. Everybody think about hematology already? You guys want to ask a hematology question? Good. I don't want to answer hematology questions, so whatever. Yeah. All right. Here we go. I know it's Friday. Seems like Monday. You guys got hit in the face this week. You're in a change of command. How many people figured out what change of command was, by the way, before? Good, I hope you did. You've been in the Army or been in the service more than like a week and a half. You see a sudden change of command at the beginning of the day for no reason and your POI time is cleared. Yeah. All right. So acute kidney injury. Again, we're going to define some terms. And it's important because really, what is acute? What are our markers of acute kidney injury that we've already discussed? BUN, creatinine, and EGFR. GFR, that's right, okay? And so they're going to go elevations and declinations in opposite, right? So as BUN and creatinine go up, that means EGFR is going down. We're accumulating nitrogenous waste products that we should be getting rid of. And that is what azotemia is, all right? So if you see a term in the literature as you're talking pre-renal azotemia, post-renal azotemia, it's synonymous with renal injury, kidney injury, okay? You used to hear this, and you might still see this in older texts or older literature, identified as acute renal failure, okay? It's not necessarily that, so that's an old term for acute kidney injury. Again, it means the same thing if you're reading through the text. It's what we're talking about, an acute state where the kidney's function is declining rapidly, all right? Uremia is what we're going to get to when we talk about chronic kidney disease. It is the end state of protracted azotemia. So if the kidneys don't function for long enough, eventually they can no longer function. And then we have constitutional symptoms of all of that inability to manage electrolytes, manage fluids, manage acid base, so on and so forth, okay? And so this is the definition of AKI. Now, in a place, I have it on here later, and it's on the home page of the Canvas, but KDIGO, or the National Kidney Foundation, those are good places to go. KDIGO means Kidney Disease Improving Global Outcomes. That's the worldwide organization, or the National Kidney Foundation. That is the American one. That's where you go to for your guidelines, your CPGs. How do I treat this? And that KDIGO is what where these definitions come from and where the actual breakdowns and the categorizations of acute kidney injury go, okay? But do you guys remember me talking about this bullet right here in relation to BUN and creatinine ratio, right? As GFR declines, the tubular secretion of creatinine increases. What does that mean? The opposite of that. Yeah, tubular reabsorption is bringing stuff back in. Tubular secretion is pushing it into the tubules, getting rid of it. As GFR declines, the tubular secretion of creatinine increases. What does that mean? It means you're trying to get rid of it, right? GFR is declining, BUN creatinine are accumulating. Kidneys now kick overdrive and try to kick out as much creatinine as possible. While that's happening, what's happening to the BUN? It's staying up. It's not as noxious. This is a simplified way to think about it. But creatinine is worse for you than BUN. If you have to think about it very simply. Is that true? No. Okay? But creatinine is a sign of more profound renal damage. So when the creatinine starts to rise, what does that mean really? Intrinsic renal disease, true renal disease. The kidney is failing now, okay? So that's why that BUN creatinine ratio starts to go down, because the bottom number of the BUN creatinine ratio is going up, okay? So that's why, and that's why it happens, is because when the kidneys start to become stressed and strained and what have you, injured, and for whatever mechanism, creatinine secretion increases, get rid of it, until it can no longer do that. Reaches a tipping point, that's intrinsic renal disease, all right? That's what we're going to talk about. That's what we are talking about today. You don't have to memorize this, but there are definitions that define acute kidney injury. And remember, kidney injury can be two different things. It can be de novo, meaning brand new injury, otherwise healthy kidney patient that has now new kidney injury, or it can be acute on chronic, right? It should stand to reason that somebody who has chronically damaged and injured kidneys has a higher likelihood or is more predisposed to develop chronic acute kidney injury, right? An abrupt failure, right? If your kidneys aren't working as it is, right? If you have an old car, it's more likely to go out, right? If you have a new car, it's less likely to go out, right? Does that make sense? Okay. So, either defined by GFR reduction or urine output oliguria, okay? Does anybody know what oliguria is defined as? Anybody know the threshold of oliguria for an adult in a day? Huh? 400. Close, yeah. 400 milliliters, yeah. So, 24 hours. But there are also stages. You don't have to memorize these as well, because again, this is something to look up later on. What you're looking for, where we need you to be, is recognition of acute kidney injury in and of itself. All right? Which means paying attention to values sometimes you might not normally pay attention to. But Stage 1, the way, if you're an easy one, you know, stage 1 has numbers, has 1, stage 2 is 2 to 3, and conveniently stage 3 is 3. All right? So I don't know if that's why they did it, but that's what I recognized when I saw it. So it's not, but again, don't memorize it. It is not worth memorizing. Just understand that the worse the creatinine accumulation is, the worse the GFR is, and the lower the urine output is, the higher degree of acute kidney injury this patient has. But as far as memorizing the actual numbers, you're not going to get any test questions from me on this stuff right here, just so you know. I told you I'd be straightforward, not trying to throw a curveball. Gold standard, serum creatinine, right? What have we talked about? Even the very last block, meaning the proteinuria. What is the albumin estimation, spot estimate based on? Urinary albumin to what ratio? Creatinine ratio. And creatinine varies greatly from patient to patient based on physiologic parameters. We talked about that in the first one, right? Muscle mass has a great deal to play in creatinine. So does age, so does gender, okay? So it's imperfect as a marker of renal injury, right? So it's imperfect. Creatinine clearance isn't the best way to identify markers. And we've talked about cystatin C as a novel marker, right? So we will start to talk about now what is cystatin C and what does it do and when should I use it? And in a nutshell, it's when you diagnose chronic kidney disease. When you get to a patient who has a persistently low GFR, you get a cystatin C to confirm and make sure that it's not falsely reduced based on creatinine parameters, all right? But ultimately, what is this? What is this little arrow pointing at? It's pointing at this bullet that says a more perfect biomarker is unaffected by other biological parameters, meaning that everybody in this room, if you got a cystatin C, that thing means the same thing for all of us, right? No matter age, race, gender, musculature, medication, anything, it means the same thing. Whereas creatinine clearance may vary from person to person to person to person, okay? Not greatly, but enough to where it throws us off. And so, this, again, you don't have to know this, but this is where a lot of the advancement in science is happening in nephrology, trying to find a good marker not only of the establishment of acute or chronic renal injury, but the site of renal injury, the start of renal repair and recovery. And so there's tons of them, right? And so memorize this list. So just tons of them. And it really, if you look, because, you know, for a while, all we really had, and just not to talk about this slide too much, but all we really had was creatinine clearance, GFR, BU, and creatinine, just to see the gross numbers of is it happening. But there's really no way other than clinical improvement to tailor treatment to this patient. And what happens when somebody's kidneys have failed? That is the definition of critical illness, right? They are critically ill. They're high morbidity, high mortality. So what these things are markers to tell us that treatment isn't working, or it's happening, the injury is at this specific site in the renal mesangium, right? Or treatment is working, we're seeing kidney recovery. So you can tailor the therapies more so to be more renal protective and have better outcomes for these patients, okay? So it is, you know, as close to cool as nephrology gets, which is very far, right? So here it is in a nutshell, you know, good, healthy red kidney and a gray dead one, right? We're trying to not get to the dead one, right? So, here's the other part I didn't mention, susceptibility. So if we have patients at increased risk, there on the bottom, under increased risk, if we have somebody with chronic kidney disease, we can identify that they're more likely, or they're establishing higher risk of a certain thing developing, so that we can then alter medications, change treatments, change dosages, what have you, so that we don't push them into an acute on chronic injury state, all right? Now, look at this. Exposures versus susceptibilities. There's two different major intrinsic renal diseases, ischemic and non-ischemic, okay? Ischemic and nephrotoxic. So looking at this, what do sepsis, critical illness, circulatory shock, burns, trauma, cardiac surgery, major non-cardiac surgery have in common?
They make hypovolemia.
Hypovolemia, a risk of significant hypovolemia, significant and protracted hypovolemia, exactly. right? Real risk of kidney injury. Sometimes the biggest risk of cardiac surgery is what happens in the kidneys, okay? And then on the bottom, nephrotoxicity, nephrotoxic drugs, radiocontrast agents, and poison. Nephrotoxicity, right? So exposures to protracted hypovolemia or exposure to some nephrotoxin, something that's going to kill the kidneys directly, all right? And then on the other side, that's our risks. Right? On the other side is our susceptibilities, right? Susceptibility to true renal injury, volume depletion, age, chronic kidney disease, other chronic diseases, and diabetes. I think every list has diabetes on it, right? Except what is good for you. Diabetes not on that. All right. So this is what we're going to talk about. These, not all of them, actually most of them, okay? And how they present and what we do with them. So this is just a roll-up. Generally, even acute kidney injury doesn't present acutely. If that makes any sense, okay? Overtly, maybe a better way to put it, right? So we have somebody who has dark urine. Otherwise, they feel kind of normal, all right? That is mostly what pre-renal injury looks like. Post-renal injury, we have somebody who has a kidney stone or prostate problem. They have a little bit of urinary hesitancy or frequency, but they feel kind of okay, but their kidneys don't. In the middle, it's a very different story. That's where your critical illness is, but it can present pretty innocuously, truthfully, all right? So, this is how I break it down in my little ring, okay? Upstream, downstream, and in the kidney itself. So we say pre-renal azotemia or pre-renal acute kidney injury. You guys have heard me say, if the flowers don't get enough water, what happens to the flowers eventually? They die. Okay? So, pre-renal azotemia, perfusion-related problem, something happening before the renal artery enters the kidney is preventing enough blood from getting to that kidney. Okay? Does that make sense? That's the easiest way. Everybody in this room has experienced pre-renal azotemia because everybody in this room has been dehydrated. Okay? Truthfully. But again, remember what I said. Don't think about this healthy people sitting next to you. Think about an infant. Think about an elderly person who is comorbid. They can handle minute fluid shifts before they go into an acute kidney injury, right? Now, on the other side, post-renal injury. What does that mean? Anything after the urine dumps into the renal collecting system or even potentially in the renal vein. Things that are leaving the kidney, right? Kidney stone. Kidney blockage. Urethral stricture. In men, prostatic hyperplasia, right? Things that block the flow of urine out or the flow of blood out. Does that make sense? Okay, how is that going to cause a renal injury? Hydroureter to hydronephrosis to then remember that picture as it's squeezing out that renal parenchyma. So we're losing usable nephron mass because it's being replaced with empty space because the urine can't escape sufficiently. All right. And then what happens if one or both of those two things go on long enough? Where do they meet? In the middle. And now you have intrinsic renal disease. And so on this side and on this side, 1 and 3, what do you think your BUN is going to be? Elevated, normal, low? Elevated. Elevated. That's right. Where do you think your creatinine is going to be? Normal-ish, right? Maybe not 1.2, maybe 1.4, maybe 1.8, maybe even 2, right? But normal-ish, right? But the BUN's going way up, like in the 40s or 50s or whatever, okay? Right, good, yeah, okay. Where do you think fractional excretion of sodium is going to be? High or low? It's going to be low, right? Because the kidneys are still doing what they're supposed to be doing. The kidneys are still alive, right? Remember, perfusion related. Think about pre-renal azotemia, maybe the easiest conceptual one to come up with. If the person is hypovolemic, what should we be doing with sodium? Keeping it to try to preserve vascular volume. And if we're not, That's the sign the kidneys are no longer doing what they're supposed to be doing. Now we get into the middle section. BUN is high, creatinine is high, fractional excretion of sodium is high, urinary osmolality is probably low, right? Because we're not concentrating our urine anymore, because it can't concentrate urine anymore, right? So the one that doesn't make any sense, right? We don't have dilute urine in the presence of hypovolemia, right? What else might we see in intrinsic renal disease that we've already talked about lab-wise? Microscopic urinalysis. Protein, sure. Tubular epithelial cell cast, wherever that came from. Yes. Tubular epithelial cells, tubular epithelial cell cast, granular muddy brown cast. So we already know a lot of this stuff. Okay, now let's put it together. All right, here's a picture that I made. You're welcome. All right. Upstream, downstream, and intrinsic. Okay. The vast majority of renal injury, AKI, is going to be pre-renal disease, something to do with volume depletion. Okay, followed probably by intrinsic renal disease, which is just a prolonged course of hypovolemia. But even in that, most of that's going to be tubular cell injury, so tubular necrosis, right? And what do we say? Tubular necrosis, not ironically named. Tubular ischemia becomes tubular necrosis, right? There it is again. See, I told you, so many repeats. I just like to play with pictures on PowerPoint. So, any questions so far? That's the baseline. Okay. If you can remember that, you can put together most of the rest of this just by the labs. And that's why we do labs first, so that it makes sense when we start looking at them in light of physiology. Does that make sense so far? Sort of? I know it's been a lot today, y'all. I understand. But we gotta I'm sorry, I tried to find a way to get rid of the second class, but we gotta utilize our time, so you gotta bear with me for a little bit longer. Does anybody have any questions? Is it sort of clear? Okay. All right. So, most common. This is most commonly what you're going to see. How often are you going to see a dehydrated patient? How often are you going to see a patient with vomiting? How often are you going to see a patient with diarrhea? How often are you going to see a patient who exercised too much and didn't drink enough water? How often are you going to see a patient who maybe took the second dose of diuretics? You know what I mean? And again, don't think of the healthy patient that comes in with diarrhea. Think of the unhealthy patient. Think of the nursing home patient that develops diarrhea or vomiting. Okay? And it becomes really a more critical situation at that point. All right? And again, guess what everything on this slide almost has in common? Relative lack of blood flow to the kidney, to the glomerulus, okay? Long-term, NSAIDs can do this because they affect prostaglandins at the afferent arteriole, so they prevent dilation of the afferent arteriole, meaning what? Meaning the end pipe to the glomerulus isn't allowed to be big enough, so it causes relative hypoperfusion for a long enough period of time. I went to a lecture and it said, you know, the nephrologist was like, what, you know, one of the things that keeps nephrology in business and buys boats for nephrologists are NSAIDs, all right, which are very common, ubiquitous, if you will, right? So be judicious in your use of them or your duration of use of them, all right? So everything on here, pretty much a reason for a patient to be hypovolemic, pretty much a reason for kidney not to be receiving enough blood, all right? So, one of the reasons why it's important to talk to your patients about their medication history, okay? So I told you, NSAIDs inhibit prostaglandins, afferent dilation, right? Afferent goes into the glomerulus, right? So if we're preventing dilation of the afferent arteriole, what does an ACE do? Efferent vasoconstriction, right? The ACE inhibitor attempts to clamp down the efferent arteriole to create that back pressure, right? So, ACE does that. An ACE inhibitor prevents that from happening, okay? So if we have NSAIDs that are preventing dilation of the end pipe and ACE inhibitors that are preventing constriction of the out pipe, what happens to the ball in the middle? Exactly, nothing. There's not enough blood going into it. Now we have created iatrogenically, because of a medication combination, an acute kidney injury. Okay? And that's what this represents, right? So ACE inhibitors prevent efferent arterial vasoconstriction. NSAIDs prevent afferent vasodilation. Not enough blood going in, too much blood going out. Stuff in the middle is not getting enough water, and now we've created an injury. Very important when you think about your medication combinations, what you're giving to your patients. How many people are on ACE inhibitor? Everybody. How many people are on NSAIDs? Also everybody. Just be careful with it. Does it happen every single time? No. But I have a patient who has chronic kidney disease, an older patient. You have to be really careful with the medications that you combine, because you can easily create an acute on chronic injury, okay? So, for prerenal AKI, like I said, this is, to me, the easiest one to conceptualize, because it just is a function of the kidneys still working. The kidneys are under stress. They're not getting enough blood, but they are still compensating. They're still alive. All right? So what is the treatment of the underlying disorder? Reperfuse the kidneys in whatever fashion you need to. Reperfusion of the kidneys will solve prerenal AKI. Okay? Now the labs. Do the labs make sense as we look at it? Does it make sense that the BUN is going up, so the BUN creatinine ratio is going up? The BUN creatinine ratio is increased. Does that make sense? Creatinine is staying relatively stable. Relatively stable. Again, it might bump a little bit, but relatively stable. So overall, the number is still going up because BUN is going way up. Okay? But again, at the bottom number, the denominator is staying close to baseline. Close. Urinary sediment, bland. Remember what I said that meant? Unremarkable, basically, yeah. Or the hyaline cast. And what do the hyaline cast mean? Not much. Nothing, yeah. Okay? Again, we're not seeing red cell cast, we're not seeing tubular cell cast, so on and so forth. Urinary sodium, even though I don't have the number on there, usually a less than sign indicates it's slow. So is that appropriate? We're not peeing out our sodium? Yeah, to hypovolemia, that is very appropriate. And the fractional excretion of sodium, therefore, is also less than 1, so appropriately normal. So looking at these labs, you can appreciate that this patient is in a prerenal state because the kidneys are still functioning. The kidneys are still doing what they're supposed to be doing. Does it make sense how you can decipher that from the labs alone? Okay. Treatment, water. Restoration of euvolemia. Okay. And then obviously it's much more than that. But, you know, not everybody needs to be admitted. That's why there's a star there. You know, consult nephrology. You know, if you have an acute kidney injury, you need to call the kidney doctor if they're available, so they can at least take a look at the patient. Critical care, internal medicine, whatever you have at your disposal. And we're just making sure that we don't give them anything that's going to incite nephrotoxicity. So we don't give them, if they're in pain, we don't administer NSAIDs, so that we don't exacerbate a problem that already exists. All right? But again, this is a function of the kidneys that are still working. As long as we re-flush them with water, everything should stabilize. And then whatever the underlying disorder is. Is that physiology pretty straightforward, you guys? Ish? All right. Post-renal. Okay? Where are we at? When did I start? Question. Oh, yeah.
Real quick, with elevated urine osmolality, is it because I'm losing sodium in my urine? Is that where
No,
the
no.
increase-
No, so don't put urinary, don't put, where are we at? Let me go back. Urinary osmolality. Don't put that together with sodium alone. Just put that together that urine is being concentrated. So not only is the kidney keeping sodium, it's also keeping water, which means what's coming out, the tubular filtrate, the ultrafiltrate, the urine is concentrated. So we are, in response to hypovolemia, we're keeping volume. Yeah. Any other questions? Okay. Okay, so post-renal, also simple, right? Just a dam, an obstruction, a dam in the river of some reason or another, okay? And over a long enough period of time causes intrinsic problems, not a perfusion problem now, but basically a waste product escaping problem, if you will, okay? Whether it be in the renal vein or in the ureter itself, okay? Because renal vein thrombosis can technically cause a post-renal azotemia. Very weird zebra, I just mentioned it. But most likely what you need to think of is the easiest conceptual patient for this side is your older man who has an enlarged prostate, who has difficulties emptying their bladder fully over a long enough period of time. You get bladder expansion over a long enough period of time. Now it starts to go back in towards the kidneys and then eventually obliterate that space, which is hydronephrosis, right? And then that's acute kidney injury. So sorry. So yeah, again, this is your most common one, right? It's the easiest way to think about it, in my opinion. Also, acutely, if you have a large stone, they can get acute obstruction. If you have a neoplasm, which is weird again in the ureter itself, that's a possibility. Anything that will obstruct urinary flow, okay? Clinical manifestations, again, mostly going to be clinical manifestations of lower urinary tract symptoms. It's going to be frequency, patient has to feel like they have to go to the bathroom all the time, urgency, they feel like they have to go immediately, hesitancy, they can't empty their bladder, things like that, things that go along with, obstructive processes, excuse me, okay? This one right here, they give you anuric, polyuria is the wrong term, I need to fix this. It really is more they experience urgency, which is not the same as polyuria. Now, urgency is that, you've seen the commercials, like, do you feel like you have to go to the bathroom all the time? And when you go, you feel like you haven't completely gone, so you feel like you have to go again. Like, that is urgency, or frequency, okay? Labs, gonna be the same, okay? Bland urinary sediment, increased BUN and creatinine ratio, fractional excretion of urine, fractional excretion of sodium increases as the process or the pathology increases over time, but typically it's still going to be low, so we're conserving sodium appropriately. And urinary sodium is variable depending on the state. So urinary sodium here, less useful, but the big takeaway on these labs, BUN and creatinines staying relatively, or BUN's increasing and creatinine staying relatively stable. Okay? So very similar labs to pre-renal. All right? And then a couple of GWIS things and we'll take a break. If there's an obstruction, get rid of it. This is more of a surgical problem typically. This is getting the stone out. This is reducing the size of the prostate. This is removing the neoplasm or what have you. Okay? And then this is just a GWIS. After you have somebody who has a long-term urinary obstruction, they're going to have a post-obstructive diuresis because the renal cells the tubules basically aren't reabsorbing water appropriately, so this